All right, welcome everyone. Thank you. We're ready to kick off here. I see we got 75 participants with us. Hopefully the number will continue to go up. We have some great content for you. This is our webinar 2, as you can see on the slide, but technically it's webinar 3 because we also had a progress webinar, progress check-in last month. So that's what the approach we are taking. Every alternate month, we're going to have a Deprescribing optimization call like this one, and then alternate with that is going to be an implementation or a progress check-in call where we'll be bringing messages and best practices from the field. With that, welcome to webinar number 2 from the AMDA and the Deprescribing Drive to Deprescribe team. The title is Optimizing and Deprescribing Antihyperglycemics. With that, we can go to the next slide. We see that we have a lot of new participants joining the call today. So, somehow I lost the slides. Was it Erica who's sharing the slides? Because we have lost the slide. At least I have lost the slides.
Yes.
All right, there we go. All right, let's go to the next slide. So, at least for this call and maybe a call or two, we're going to continue to focus on some of the basics of optimization, medication optimization, and deprescribing, because a lot of new folks I see on this call. So I think that focus on the basic foundations of medication optimization and deprescribing will be important. So you may have some repetition on this call about those concepts. The objectives are in front of you. We really want to learn about medication optimization, deprescribing approaches, what is the role of various members, and then specifically look at an algorithmic approach to how to optimize antihyperglycemics. Let's go to the next slide. So just to remind everyone that we have a lofty, ambitious goal of 25% reduction of scheduled medication in long-stay patients. Of course, it does not mean that we should not be utilizing these principles for short-stay patients, but we really will be evaluating our progress and success, basing it on long-stay residents. And you can imagine why, right? I mean, those are the residents who are really under our longer care, and it's easier to relatively have a conversation about medication optimization and deprescribing. We will provide you a lot of tools along the way, which will always be available on our D2D website. Next slide. As you can see that we are using an approach called a predetermined approach to deprescribing, which basically means that we target one medicine category, and then we establish some deprescribing eligibility, and then we implement the program and we monitor our success. And we actually are using a lot of resources on this project through deprescribing.org, which is a Canadian organization or leadership group, where they have given us some great evidence-based guidelines and algorithms on these 5 classes, including proton pump inhibitors, antihyperglycemics, and few other, as you can see on the slide. And Sabina, thank you for reminding everyone that we will be relying on the chat box. So please put your comments, questions in there, your suggestions in there, and we will be highlighting some of those today. You're welcome, Lisa. All right, next slide. We just to remind you, we did share this slide last time also, that none of us on the call on this D2D team claims to be an expert. We are just barely cheerleaders. We basically, as AMDA members and members of the PALTC, a group, we really believe that this is a topic which is worthy of our attention, which should stay under our focus pretty much all the time. So we are barely just cheerleaders of this. There are many different ways of deprescribing. There's many experts among you I see already on the call who have excellent track record of leading this. So we really do not claim to be an expert. We really just propose to be cheerleaders for this and to make sure that we keep this very important topic in the center of everyone's attention. All right, next slide. This is just some of the key lessons which we learned in one of the initiatives which we published a few years back, strategies that may help many of you in leading any initiative, but specifically around medication optimization and deprescribing. Always try to start small, and then once you gain momentum through some early successes, then you can go a little bit bigger. Always important to have at least one, but more champions in your buildings. It could be the pharmacy consultant, it could be your DON, it could be the nurse practitioner, it could be you yourself, right? But assigning a champion from the facility side and more than one champion who can lead this cause is going to be very important. Make sure that you do not overburden the staff or yourself, and really try to incorporate the work that needs to be done under your current copy processes. Very, very important to share data or any successes, no matter how small they may be, with the rest of the group in your facility. That motivates people. Even if you're not having success initially, being humble about it and recognizing it and then discussing the barriers is a very, very important strategy. So really pay good attention to where the data is and make sure that you look at it together as a team. Always think about small ways of celebrating. Social acknowledgement can go a long way. Setting some competitions, which at my own organization at Signature Healthcare, we are actually going to lead off a large competition among facilities, which we'll talk about on the further subsequent calls. It's a very good way of implementing a project like optimization of medication. And then take the initiative beyond the facility walls. Beat the drum of what good work you're doing across the system to a local healthcare system, get their expertise, get them involved in it. And then the momentum gains. It becomes really hard for a project like that to fall off, because then there's a broader group that is getting involved in this. Next slide. Now, some of the things which we have shared in the previous two calls that you had, these are some of the things which we believe you will have to get involved in quickly if you really want to sustain a successful and effective project like D2D. You have to, of course, engage your facility, needless to say. And we have provided you many resources on printouts, posters you can use so that every staff member can be aware that you are implementing this in your facility. Make sure that you assign a formal D2D team. Of course, you can be a team of one as a medical director or a physician or a nurse practitioner or a pharmacy consultant who's very engaged in it. That's fine. You can gain some success, but your success will multiply and amplify if you can really have a formal team of interprofessional leaders in your facilities. Of course, DON, the pharmacist, medical director, nurse practitioner, maybe another prescriber are at least the minimum. But of course, you can have other members or other ad hoc members who are ready to be engaged as needed. And there's some examples for you on that. And at a corporate level, if you're a larger group of facilities, it is very important to create in parallel corporate D2D team also, so that the messaging is consistent, both at the corporate and the headquarters level and also at the facility level. Buy-in all across around this initiative is going to be very, very important for success. Next slide. These are some of the key logistics you will have to, if you have not already addressed, will have to address. Please set up a time and day in a month or a couple days in a month to meet. It could be your copy day, so it doesn't have to be a different day. These are the days where when you come together, you can at least definitely think about discussing a couple of complex cases so that everybody can learn principle of deprescribing. Make sure that your pharmacy consultant is helping you to make sure that the data is available in a meaningful way. We again have many examples on the D2D website, and we are actually requesting from our pharmacy partners this data. We will be sharing some of that data today with you. So exciting thing to look at later today. If not yet planned, create some energy by announcing a facility-wide kickoff for a D2D project in your facility. That just creates more excitement about the initiative. Next slide. Again, there are many tools available on the D2D website. These are communication tools like flyers or letters you can use for the family or other physicians in your facility. And then there are specific tools such as the stop, beards, criteria, and so forth. And we're going to continuously add tools as we go forward in this initiative. Next slide. I just want to share with you, because I really love the simplicity of this paper, which was just published recently by Dr. Dharmarajan and others in JAMDA just a few weeks ago, a few months ago. It's just deprescribing is a simple, rather it can be a very simplistic project. It is basically knowing your patient, knowing their comorbidities, knowing what medications they are using, and then coming together at an interprofessional decision. Is this medicine helping? Is the PPI, is the vitamin really helping this patient? And then deciding if it's not, then coming up with a evidence-based strategy to how to deprescribe or how to taper. So really, it's such a simplistic process. It does not have to be more complicated than that. So just this paper highlights that very clearly. So I think those are some of the key messages we wanted to bring to you. We are very excited to announce that our new medicine for this focus for the next 60 days is here. And I'm going to invite now Sabina as one of our experts to kind of talk about our next class we are going to be going after for optimization and deprescribing. Thank you so much.
Thank you, Arif. No, I'm not an expert. I'm just a medical director.
Well, I would say that Sabina is definitely an expert, even though she's being humble on deprescribing antihyperglycemics. So she has just amazing.
Okay. Well, it is. I'm just so glad to see so many of you here. And antihyperglycemics is something that I'm, if not an expert, I'm at least excited about it. So we're going to run through how you actually deprescribe when and if and when and how of deprescribing antihyperglycemics. Let's go back. So we have a patient, Mrs. Smith, next space here. So Mrs. Smith is an 80, just to refresh your memory, she's an 88-year-old former school teacher. She was widowed 5 years ago. Prior to coming to your SNF 8 weeks ago after a hip fracture, she lived in her own house, but needed a lot of support from her two very involved daughters and part-time caregivers. She carries the diagnosis of dementia, hypertension, hyperlipidemia, diabetes, obesity, CKD, AFib, diastolic CHF, CAD, osteoarthritis, osteoporosis, and incontinence, and suffers from depression and anxiety. Sound familiar? Yes, probably. She's a very typical patient, and she is also our poster child for hyperpolypharmacy. Next slide. So these are all of her meds, and they're like overwhelming, but it is realistic. I have seen this, we all have seen this, patients coming in after they've seen by specialists and so on. Last time we looked at PPIs, and we discontinued the ibuprofen and the MVI. And in the meantime, we were going to figure out what was with the omeprazole. And in fact, the patient did not have symptoms of GERD after the stopping of the ibuprofen. And she didn't have a history of GI bleed. So that medication was successfully being down as well. Now she is on insulin sliding scale, metformin 500 BID, and glyburide 2.5 milligram BID. And let's just see what we know about her diabetes. So this is something we would be faced with, and Dr. Schmitz and I, for example, we'd be looking at, okay, what's the evidence for her diabetes? Next slide. So a hemoglobin A1C recently obtained was 6.7. What we know about that is that would be great in a 50-year-old, not so much in a 85-year-old demented patient. And in fact, a higher hemoglobin A1C is associated with better life expectancy and outcome. They do an acute check, QID, on a regular basis every day, and we see that she had several chem sticks less than 100. Her sliding scale was a discharge medication from the hospital, and she gets interventions for blood sugars about 3 times, if above 180, about 3 times a week. She feels weak and dizzy at times, and she does absolutely not like the 4 times a day chem sticks. And should we deprescribe her medications? I think the resounding answer to that is yes. Why don't you just take a second and write what you would do now into the chat, or the questions you have around that, and then I will, in the meantime, walk you through what the fabulous folks of deprescribing.org pulled together. They have this evidence-based, somewhat busy looking algorithm, but let's unwrap that a little bit because it's really not that complicated. Next slide. So first of all, who is a candidate for deprescribing? does your elderly patients over age 65 with type 2 diabetes, so that's important, have the following criteria: hypoglycemia. And what would that be? Advancing age, comorbidities, drug interactions, impaired renal function, are on the sulfonylurea or insulin. Do they have, are they experiencing, or are they at risk from side effects? And what's really the clinical benefit of tight? Is there a clinical benefit of tight glucose control? Next slide. So the way you would then look at this, if these criteria are met, then let's just take the next step and set an individualized hemoglobin A1C and blood glucose targets, and really consider that it takes about 10 years to derive benefit from tight glucose control. If they don't will have a benefit from that, then we're looking at hemoglobin A1C of 8.5, blood sugar usually less than 220, even if it's an end of life, and given a certain situation, our Canadian friends think that less than 250 may be acceptable. Next slide. The next thing would be, what are contributors to hypoglycemia? And one of the things that stands out here is sulfonylureas, of course. And let's just look at the next slide here as well. And then recommend deprescribing. And how do you deprescribe antihyperglycemics? You either reduce the dose and stop the agents, and the hypoglycemic agents that really stand out here are sulfonylurea and insulin, or you switch to a different agent with a lower risk of hypoglycemia, or you also could reduce doses if you have hypoglycemia going on. And you see she is on metformin. She's not on the maximum dose of metformin, but she has CKD, so she would be potentially a candidate to decrease that. Next slide. So here are the medications that are causing hypoglycemia. And of course, high on the list is insulin, and then sulfonylureas. That was actually when I trained in the 80s, and I know I'm dating myself, that was the mainstay of treatment. But you know what? We're not in the 80s anymore. And I refuse to practice last century medicine. Next slide. So once you make your decision, you then just monitor. And you look for, of course, clinical signs and symptoms, and you monitor a little bit more tightly than you will moving forward. Next slide. And if hypoglycemia continues, you move further on in your strategy. And if you have symptomatic hypoglycemia, and if you don't meet your predetermined targets, it may be time to pull back on that deprescribing a little bit. It's that simple in the end. Okay, next slide. So here's what the committee decide. And I want to see, like, I only got one comment on what to do with her. That's the DC statin. That's another discussion that we will be having, whether we should or should not continue in a statin in a diabetic who is 85 years old and demented. We will have that discussion. But here's what the committee decided. We looked at a individualized hemoglobin A1C goal. And we're talking about a long stay patient here who's 85, she is demented. She certainly does not have a 10-year, and in the nursing home, she does not have a 10-year life expectancy. So our hemoglobin A1C goal is, the upper range would be 8.5. And she has hypoglycemia, so we're going to stop the glyburide, and she's now 6.7, so there's no reason to give her a glyburide right now. We stopped the sliding scale. Very few actions derived from this very intensive intervention at this point, but we are keeping the metformin. And then we're going to lower the AccuCheck. So we're going to check it daily at varying times for 2 weeks, and then 2 to 3 times a week. So we stop, we keep, we monitor, and then we'll start something, which is an annual eye exam, which she hasn't had for a while. So it's not about taking away. It's really, when you see this, it's really about optimization. Next. So, and what are we going to do with their daughters? You know, she has these 2 very involved daughters, and they may come to you, and Jen gave us a really beautiful way to approach that, but they may come and say, you know, my mom has been on glyburide since the 80s, and why are you taking that away? And here is something that we're also getting from the deprescribing.org website. This is for families and patients to go with them step by step, and really talking about why we would consider reducing or stopping or changing an antihyperglycemic. Next slide. So we are on the road for Mrs. Smith. We are now targeting the insulin sliding scale and the glyburide. I think the metformin may also be on the chopping block, depending on how she does with this. And I think with that, next slide. Oh, yes, I wanted to show you how this approach worked for me. So and I'm not an expert, but I certainly have experience, and experience is what you get when you don't get what you want. And I didn't get what I wanted when I looked at my insulin sliding scales in my company and throughout all of our facilities. We had a significant number of insulin sliding scales. The way we got to that was that we had an initiative. I try to have a yearly initiative and goal for our medical directors and for me as a CMO. And one of the goals we had is to pursue safety goals. There are no national nursing home safety goals that are formulated like hospital safety goals, and those of you who are hospitalists may have seen them, but one was certainly high-risk medications. And so we looked at, choosing wisely, and then really, insulin sliding scales are a high dose medication and a safety hazard. So we, again, very simple, really, obtained pharmacy data on insulin sliding scale. So all of you who are on this call, your pharmacy can get you that. Lots of diabetes education and tools. How do you decrease the sliding scale? Not everybody is, of course, that straightforward. The CPGs on diabetes from AMDA have some good tools there too. And then we formulated a goal. I want less than 10% sliding scales for my patients. And then, and all of you who are, either in corporate medicine or work with CROPI, we incorporated it into our medical director scorecards. Next slide. So this is a scorecard. This part of the scorecard, and you see there was a lot of red. Particularly here, still there's a lot of red on the percent of residents with diabetes on insulin sliding scale. I present to you that that is not much improved. Next slide. And here is what we then got from our pharmacy partner, and in this case, this was Omnicare. They were able to present me or give me these data that I then could share with my board, and most importantly with my medical directors. And I'm really proud to report that we were, although it wasn't from one day to the other, but we were able to chip away at these sliding scales from a 33% prevalence of sliding scales in our diabetics to 16.4. We have since gone down. So we company-wide haven't quite met that goal yet, but we were a relative reduction of 55%. I was really proud of that. I'm proud of my providers and my medical directors that we were able to achieve it. So it's really not rocket science. It's really a simple process. Let's just say the process is simple, but the execution you have to have, it's not a sprint, it's a marathon. And I think for you as leaders, whether you are medical directors, physicians or nurse practitioners or PAs, you are leaders here and you can make that happen for your patients. Next slide. And with that, going from my data to our data. Michael Sinkler is the pharmacy vice president for Genesis.
Yes, yes.
All right. And take it away, Michael.
Thank you. So what an excellent presentation. And not only was it a great clinical presentation, it ended with data. Because at the end of the day, you know, we know that what gets measured gets done. And as part of our D2D program, we're working with 3 primary pharmacies to collect utilization data. And if your organizations have signed up for this, then they'll be sharing de-identified your data with us, and we're going to be able to see how we're doing as a group together. And then you're going to be able to see how you're doing individually. So this is D2D baseline data version 1.0, okay? So it's got some room, but it's a start, right? So this first data set that we have has 2 of the 3 pharmacy providers, Pharmerica and Consonis. Omnicare is close. I saw their data today. They are still in the tweaking mode, and I expect to have that real soon. But what I'm going to be able to share with you today is our results of a data set that involved 20 submissions, 510 facilities, facility chain individuals that ranged from a single to 212 facilities per group, with an average patient to facility size of 52. What's so exciting about this is the data that we're looking at is over 295,000 scheduled medications from the Pharmerica and Consonis participants in our program. And here's the big news. For that group, the number of scheduled medications per patient is 11.22. So there, we have a baseline. And from here, we can move forward. Next slide, please. I'm going to show you some data on a couple of the classes. We've shared with you everything that we're showing, everything that we're collecting. But we're starting with, and you've seen these, multivitamins, PPIs. Today, we talked about sliding scale insulin and sulfonylureas, our favorite antipsychotics, and one that may not have been so easy to attack, but have big impact on our patients' quality of life, hospitalizations, falls, everything anticholinergics. So we're going to be targeting those also. This is important. Our intervention metric is the percentage of long-stay patients on a medication in a class. Let me show you what that means. Next slide, please. So from that first set of data, what this shows us is that for all 510 facilities, 20% of these patients were on a multivitamin. Now, you may say, seems low. Does that seem low to you? It might be. If there's one metric in everything that we're tracking that might be problematic, it's this one. Why? We're using Consonis, Pharmerica, Omnicare data. And what do we know? We know that not every center orders their multivitamins from their pharmacy, right? They order them from the Medlines and the McKessons and their floor stock, right? And so they're not all included. So 20% came from the primary pharmacies, but we're not going to put a lot of faith in this number. I'm being straight up front with you. But 30% are on a PPI. 11% are on a sliding scale. That's a very large number. Smaller, about 3% on sulfonylureas, 32% on antipsychotics, and 18 to 19% on anticholinergics. So I think what you can see is we can really have an impact by focusing on these areas. So what will we be doing? we're going to take these numbers and we'll be adding the Omnicare data to it, and this will be our baseline. Next step for my colleagues at AMDA is to work with the 3 pharmacies to create your scorecard for you from your pharmacy, not from AMDA, right? It's de-identified. We don't know how everyone's doing, but your pharmacy does. If you're Omnicare, Consonas, or Pharmerica, they will give you the report to show how are you with PPIs. Are you better than the group? Are you slightly behind the group? And then you can sort of score yourself against the rest of the folks who are looking to drive down prescribing with you. So you'll compare your individual performance to national D2D results. And since 25% is our target, our goal is to take this from 11.2, which is where we started, down to 8.4. And we can do it. You're getting the tools that you need. You're getting advice on how to do it. We're hearing feedback from you. Many of you are doing it. And very soon, you'll have the numbers to know how you're doing. What are the fruits of your labor? What was your baseline and what's your monthly performance? So very excited about this. And I'm looking forward to working more with you. Any questions, please reach out. We're here to help. Next slide. And that's it for me.
All right, so what's next? Somebody asked, can I use this slide? And the answer to that is not only absolutely yes, the answer is for me is like, do it. Yes, do look at these slides and share them with your clinical group, with whoever you want to really, and educate everybody on this class of medications, and then how you go about looking at these medications. There are several ways to do it, but the way that we have chosen is you would pull everybody who has an insulin sliding scale, or even better, and then move through those insulin sliding scales and the diabetic management of these patients one by one. And you may just do it, over a month or two, or you just get the list of all the diabetics in your facility, and that's probably about 30%, roughly. And then you go through the diabetic management of all of those patients. You would look first at the goal, then is that goal met? Are they a candidate for if not, are they a candidate for deprescribing? And what other health maintenance do they need? And keeping in mind where they are at clinical. What we haven't talked about here, but we are talking about long-term care. Of course, you all know about the tale of two hallways. We have long-term care patients, we have post-acute patients, and they may have very different goals. Keep that in mind. And then work as a team. And that if you're lucky, you can get your pharmacist. And I would, I have some facilities that I have the pharmacist, and I have some facilities where I have to over and over invite. And I think I got like my third facility that I personally have. I just got the pharmacist, reel them in. So, and I have the social workers, and just get those folks together. But if you can't, go ahead anyways, and do it. Just you and your, maybe your nursing partner. And then celebrate your success at the next coffee meeting, or bemoan your failure at the next coffee meeting. One or the other, talk about it. And I think that it is really important, and people said, oh, what great success. I think the real important thing here was that we knew our numbers and we knew what we were shooting for. And I think it's that focus that you will need. And it's kind of interesting, I'm all happy with 16% sliding scale. It's better now. But apparently you all are doing better than I did. So maybe you have another focus that is more important to you. But we'd love to know how that is going on your next call, which is in September. Please share your practices then. But I would like to open up the discussion right now for questions.
Yeah, I'm monitoring the chat box. I don't see anything specific in here, but just want to highlight that this is a great implementation peer group here, right here for you. So if I mean, this is I think it's a kind of historic energy we have built around medication optimization and deprescribing. We have 4,500 facilities presented on this initiative. We have 117 people presented on this call. So, there's a big group. So let's make sure that we use this energy to really, really nail this issue, which is so important to our residents. And please, I wish there were a way for you to tag your friends who are not on the call. So people in your facility and other facilities you work with who are not on this call or not aware of this initiative, please, please, please forward this information to them. Let them know that we make it pretty easy and burden-free, right? I mean, I think it was pretty simple how, Sabina went through and how Michael went through the data. We try to make it simple and fun. So please, please, quote unquote, tag others who you think would benefit from this initiative.
Thanks, Arif. Michael, I have a question about your data that you showed, or our data that you showed. You know what shocked me? In a way, it shocked me that we had so few sulfonylureas, so that's good. But what really shocked me is the 30% antipsychotics still. That did seem like a very high number, and also a relatively high number of PPIs as a baseline. Do you have any advice on the PPIs? We talked about that last time. What is a good goal? What do you think if everything is said and done? What should, because I want to make that a goal for us, but I don't really know where to set that. I had a detailed discussion with our medical director group on that. What is your advice as a pharmacist?
So, and we'll get our numbers when our numbers are in the Omnicare group. And so what we'll likely do is see where we are and cut it in half and just go for it. Mm-hmm. And really our strategy is going to be everyone who's on a PPI, let's make sure we really understand why.
Yeah, right? That's a good one.
And that's really what it is about, because so many times, especially with this class, it's almost deemed a comfort drug, which is not really what it is, and it's set and then it gets forgotten, and that's what happens. And we're going to reevaluate every one of them and see what we can do. So that's how we're going to approach that as soon as we get our data.
That's a good point. And speaking of being forgotten, I think the reason we continue to have the sliding scale problem is that patients get treated with sliding scales in the acute care setting. Then they come to us, and then the sliding scale stays on and on and on. And that made sense in the hospital and maybe for the immediate post-acute period. But it then stays on and on and on. And we don't, and there are studies saying that these sliding scales stay on forever and they don't even do anything because you only react to 2 or 3 blood sugars a week. So one of the ways of reducing that problem to begin with would be limiting sliding scales from the get-go, unless there are special circumstances. But if it's a new sliding scale started in the hospital, limiting it from the get-go to 14 days. That is one strategy.
Sabina, sorry to interrupt, but I do see there some activity on the chat box. I just want to point to is we have a question from Marisol. How long before the group moves on to another class? So 60 days. So next month we're going to do a progress check-in. We're going to hear from you guys, and we are actually going to be sending out a survey to you guys about what are the challenges you are seeing, and also want to get anybody raising their hand who want to really share their practices at the next call. So, so it's 60 days is what we're gonna when we'll introduce the next class here. And the other thing you're asking is, I heard reduction target of 25%. Is this a benchmark for all facilities, or facilities determine local targets? So I would say that it's a reasonable target for every facility to have in mind, but it wouldn't be any problem if you want to go deeper than that. But the 25% goal here is overall for all the facilities in this initiative. We'll be really, really happy if we can hit that. But of course, some will be a little bit less, because I'm sure there's a lot of people who already had a focus on deprescribing. They don't have that much room to move, but there will be some buildings where there is a little bit more room than that. So hopefully we can get to that 25% target. And I think there's a raised hand. I don't know if Nita, if you want to go ahead and unmute yourself and ask a question or share a comment. We have a couple of minutes left, or was it by mistake? I do not know. All right, so I don't see that anymore. All right.
What I wanted to highlight from the chat is from Lisa McCarthy regarding, I think this is regarding PPIs, is and what Michael just was saying, and I think that's true for many drugs. Write the indication for this drug down where people can access it. So if you prescribe the PPI and end up prescribing it, say it was because of a GI bleed in 2018 or whatever. So I think that communication is going to be essential. I thought that was a really important comment. Any other questions or comments from the group?
Well, there's another important comment just highlighting that there are a lot of, there's a in general lack of awareness regarding many dangers of long-term PPIs. So that's an important point. Jury is still out how much harm PPIs can cause, but regardless, we do know that they're not the safest drug if used for long-term. So very, very important to keep that in mind. It's a good point.
Yeah, I'd like to add one more point to Dr. Ryan Price-Friedman's. Think about sliding scales, and every one of those comes with ACU checks for the patient and work for our nursing team. So not only, right, is this a med that we can pull back on? This will improve quality of life for patients, and also take some burden off our nurses, which is something we can never do enough of.
Good point. Excellent. So Sabina, yeah. I think we're at the last minute. So do you want to kind of give us what's next for the next meeting?
So for the next meeting, that will be in September, we will do a progress check-in. So we will probably have one of our participants talk about their progress, the highlights, the lowlights, and it will be a all teach, all learn. So you won't hear me talking as much as I have, but I would really like to know from you, what were your barriers, what has worked for you, and so really a more an all teach, all learn situation, and we'll give some clinical information as well. But
we do have a survey coming to you guys. We would appreciate if you guys could fill it. It's going to really ask how the initiative is going so far, how's the organizational buy-in from your side, and also we'd like to hear if you have something to share for our next call. So please look out for that survey that's coming, I think, over the next few days.
All right. So I think with that, we can close this call and send you on your merry and hopefully a successful deprescribing way, and keeping your work and your interests will go a long way to keep our patients safer and feeling better. Thank you very much. Bye-bye.
Thank you, everyone. Appreciate it.